Last year, the Manitoba government announced a recruitment target of 150 family doctors in the province through a contract they have with a recruitment agency, with initial goals of 50 physicians each for Winnipeg, northern Manitoba, and rural communities. At the local level, the Rotary Club of Nipowa invited the Beautiful Plains Community Clinic on March 2024 to speak about the physician recruitment efforts in the community. Michelle Lewandowski, Beautiful Plains Clinic Manager, presented Nipowa and area's current needs and challenges with regards to physician recruitment. She also shared that despite the Manitoba government's recruitment strategy announcement last year, there are no doctors coming to Manitoba and that the provincial government is currently reviewing the said contract with the recruitment agency. With the growing population here in Nipowa and with the upcoming new hospital, more physicians are needed. There are different recruitment strategies that are being done by the local clinic, including overseas recruitment or staffing agencies and medical student exposures. Aside from the lack of doctors, one of the challenges is retaining our physician in the community, which is mostly due to the availability of housing and childcare facilities and other issues when it comes to settling in their new community. Dr. Milgan, director of the medical residency program of the local clinic, shared about how the program works and is hoping that the medical students will later on decide to stay in Nipowa and work as local physicians to address the current shortage of physicians in the community. Recently, an announcement was made by the Manitoba government on April 2, 2024, led by Premier Wab Kanu and the Minister of Finance, Adrian Sala, about the new budget for 2024, and one of the budget priorities is rebuilding healthcare by hiring 100 doctors, 200 nurses, 90 paramedics, and 600 healthcare aides over the next year, and investments to retain and train even more. With this announcement, Manitobans are hoping that this will translate to better results for our healthcare system.
Before we begin, I'd like to acknowledge the First Nations peoples of Treaty 1 and the people of the Métis Nation, on whose ancestral and homelands I'm speaking to you today. J'aimerais reconnaître que nous sommes dans le territoire du traité 1 et la partie traditionnelle de la nation Métis. I'm John Reyes, Minister of Labour and Immigration, and I'm pleased to be joined here today by my colleague, the Minister of Health, Audrey Gordon. With us as well is the Registrar and CEO of the College of Physicians and Surgeons, Dr. Anna Jomek. Thank you for joining us today. Now at this time, I'd like to invite Minister Gordon to the podium to make today's announcement.
Thank you, Minister Reyes, and thank you all for joining us today. I want to start by stating that my apologies for being late for the announcement today, and I do hope the individuals involved in the 4-vehicle collision on the St. Vital Bridge are fine. So my best regards to all of you. I'm Audrey Gordon, the Minister of Health, and it's my honor to be here today for this exciting announcement. As you know, family physicians play an integral role in our healthcare system. They provide ongoing longitudinal care for patients across the continuum of community, hospital, and long-term care, and their focus is on preventative care, including the detection of early warning signs of medical concerns. Today, I'm pleased to announce that our government has contracted a recruitment firm to recruit 150 physicians across the province. Canadian Health Labs has been retained to assist with this focused recruitment drive to recruit 50 each for Winnipeg, northern Manitoba, and rural communities. In addition to this recruitment drive, we are making it easier for internationally educated doctors to practice to support better patient outcomes and bring care and services closer to home for all Manitobans. I'm so thrilled to share that our government has approved amendments to the College of Physicians and Surgeons of Manitoba general regulation to streamline registration requirements and expedite the registration process for internationally educated physicians. Internationally educated physicians who meet all other registration requirements will no longer be required to also hold a licentiate of the Medical Council of Canada to practice in Manitoba effective September 1st, 2023. This requirement can be safely removed because specialists and family physicians must continue to demonstrate their competency by either completing postgraduate medical education and obtaining certification from either the College of Family Physicians of Canada or the Royal College of Physicians and Surgeons of Canada, or by completing the Manitoba Practice Assessment Program. We are removing provisional registration requirements such as assessments and supervision for fully licensed physicians from jurisdictions similar to the care provided and training provided here in Canada. So fully licensed physicians, I'll give you just some examples of the jurisdictions: United States, the United Kingdom, Australia, New Zealand, and Ireland have shown that provisional registration requirements such as assessments and supervision provided limited to no value. These physicians already have requisite experience from their home jurisdictions, similar health, education, and training systems as our own right here in Canada. And we are creating a new route for subspecialists to obtain full registration. So applicants who have already completed the Royal College of Physicians and Surgeons of Canada's subspecialist examination affiliate program will be eligible for a new fast-track registration process that is more appropriate for their qualifications. Finally, clinical assistants with a medical degree will be able to use the title doctor with the qualifier clinical assistant. These announcements today follow a tentative agreement reached last week between our government and Doctors Manitoba on a new physician services agreement that features overall funding increases of $268 million over 4 years. Our government is healing healthcare by bringing more doctors into the province, making it easier for internationally educated doctors to practice in Manitoba, and working to retain those that are currently providing care to Manitobans. Thank you. Merci. Miigwech.
Thank you, Minister Gordon. I'd like now to invite Dr. Jomek to say a few words.
Thank you. The College of Physicians and Surgeons is pleased the Manitoba government has approved our proposed regulation amendments that will reduce barriers for international medical graduates while maintaining public safety. These changes make Manitoba more attractive to highly skilled professionals who will make valuable contributions to our healthcare system. Changes mean that a subspecialist, such as a neonatologist, would no longer be required to maintain specialty in pediatrics, but rather will be a specialist in their limited scope of practice directly by passing the Royal College exams. Ensuring public safety is still our top priority. Physicians will still have to undergo some assessments and supervision requirements to ensure that they are competent to practice within their scope of practice. We held a public consultation about the regulation changes that we were asking government for, and the majority of people that wrote back were very supportive of our changes. We heard from physicians who are international medical graduates who said our process was cumbersome and difficult and led to delays. We heard from Canadians who trained internationally and now would like to come back to Canada, and again, the process was too difficult for specialists to come back to Manitoba. We heard from the university and Shared Health. These changes will allow the province to bring in more specialists with less burdensome qualification processes. We look forward to seeing the results of these amendments, combined with the enhanced recruitment efforts that have just been announced. We're confident that this will strengthen Manitoba's workforce to attract and continue to maintain those who are qualified and who will provide expert care to our citizens. Thank you.
We have a very interesting program today. We're going to talk about, as everyone knows, we have a new hospital coming to Neepawa, and we're going to talk about recruitment. We're going to talk about recruitment of doctors. We're going to talk about our new residency program that we have in Neepawa for training of young doctors, which I think will go hand in hand with the recruitment that we need for this hospital. So today, I have three distinguished guests. I have Michelle Lewandowski, I have Jenna Kilburn, and Dr. Brian Milligan. And I'm not sure who's going to go first. Michelle? Okay. And we have a little bit of a PowerPoint presentation as well, but I'd like to welcome them today to the front, and at the end we'll certainly have a chance for you to fire some questions as well. So,
Okay? Yeah. Okay, so thank you for having me. My name is Michelle Lewandowski. I'm the clinic manager at the Beautiful Plains Clinic. We wanted to give a quick high-level discussion about our recruitment efforts and where we stand currently with our local needs for physicians. So a quick outline for our presentation. We're going to go over our physician shortage statistics provincially and nationally, our local needs, our current recruitment strategies, ways to help physicians choose Neepawa in the future, and then Brian and Jenna will lead into our new program. So as we all know, this is nothing new. Neepawa is currently experiencing a physician shortage. Due to the increasing population size and the fact that we had a departure of 2 physicians within the last couple of years, we are low on meeting our community's primary care needs. That being said, the shortage is not unique to Neepawa at all. It is being experienced in towns, cities, provincially, and at a national level. Everyone is struggling to recruit family physicians. Manitoba currently, as you can see with this chart, is experiencing one of the biggest physician shortages in the country. Manitoba was previously ranked number 4 in the number of physicians per capita, and that has declined over the last 2 decades to second last, so 9th out of all of the provinces. With 111 family physicians per 100,000 residents, it would take 175 additional family physicians to reach the national average per capita. So again, it is not just Neepawa. I know it feels like it's Neepawa that's struggling because we never used to, but we were just very fortunate. So currently, where are new physicians coming from? When we do get new doctors, where do they come from? Right now, any new Manitoba physicians appear to be the direct result of new graduates going through residency programs and those that are trained overseas or internationally. There is minimal recruitment success from other provinces or the United States. So most importantly is on to our current community needs. And the number of patients actively rostered at the Beautiful Plains Clinic is nearing 6,500. Proportion of those with a Neepawa address versus an out-of-town address is at 10.2%. Are from out of town. However, I suspect that this number is actually much higher. Many people fail to update their box numbers, or they choose to keep Neepawa listed as their main mailing address even if they have moved away, or they simply do not change their information. So it is estimated that there are 2,000 Neepawa residents currently without a family physician just in the town of Neepawa. That number is based on the number of unassigned patients left from Dr. Cram and Dr. Ogg's departures, and the number of people who have actively sought out to register on Family Doctor Finder. Again, it's hard to know for sure, but that is our closest guess. It's also estimated that outside of Neepawa, the surrounding communities, is another 1,400 people that are unassigned without a family physician, and that we would require easily and modestly another 4 to 5 physicians to be able to meet the primary care needs of the community. And we also believe that it's about 17 physicians needed to properly staff the new hospital in total. So moving on to what is currently available for recruitment strategies, these are strategies that we have commonly used throughout the years. Examples being local physician efforts and connections between doctors. So just who doctors know and who they develop relationships with. For instance, Dr. On was the one who successfully recruited Dr. Desley and Dr. Tariq. We have the International Medical Graduate Program. This program did give us Dr. Jawed in September of 2022. And the program does train 20 physicians per year. So these are physicians that are trained in another country and come over to get their credentials recognized in Canada. So 20 physicians per year, and Prairie Mountain Health is usually slated to get about 4 for the whole region. And they are typically placed in communities with high physician turnover or that show the biggest need. However, it is rare that any of the physicians from the IMD program will settle permanently where they are placed, largely due to their religious, cultural, and family needs. They're often placed in communities where they have no connections whatsoever, and then they struggle to make connections and choose to go somewhere that can more adequately suit their personal needs. Other ways are overseas recruitment and staffing agencies. So this is hiring other companies specifically trained in recruitment to bring them over. Also, residency programs do increase community exposure amongst new graduates. And elective family medicine residents are residents who chose to come to Neepawa for more experience. This brought us Dr. Cram and Dr. Worm originally. They had actively chosen and requested to be back in Neepawa to see the community. And then again, of course, homegrown kids and kids that are from the community, like Dr. Hallie Krasaniak and Sydney McLaughlin is a current med student. Obviously, we are hopeful that they would choose to practice in Neepawa, but and an example of Prairie Mountain Health's recruitment tactics is Prairie Mountain Health has various strategies that they use to help recruit. An example being a $75,000 signing bonus to any new physician choosing to open some sort of a practice in the region. However, like I mentioned, it doesn't always work. I don't know if any of you saw this, but it was released yesterday, highlighting that there have been no doctors coming to Manitoba, let alone to Neepawa. So it's not just Neepawa specific, it's in general, the health minister had a contract with a staffing agency to recruit 150 physicians to the province, and that has resulted in 0. So even after doing this, it has been completely unsuccessful. Okay. And for the next one, we're just going to cover some high-level topics on maybe why people and new graduates have passed over Neepawa. So why have people passed over Neepawa? Other employment opportunities outside of primary care. Other physician opportunities can provide a much more lucrative compensation structure than that of a fee-for-service primary care clinic. This including being a locum, getting the locum tenens program, becoming a hospitalist, or working in emergency rooms. There are other communities that offer greater monetary incentives, signing bonuses by towns or community organizations, or clinics that just offer lower overhead for physicians. Also, another thing is they have easier access to necessary supports and opportunities in other communities, such as daycare services, housing, spouses getting meaningful employments, and physician extenders, such as physician assistants, nurses, dietitians, things that are more readily available, different equipment, CT scanners, other things draw new grads to other communities that already have these in place. So we need to start thinking of ways to set ourselves apart. Regularly seeing local businesses and groups engage in supporting medical services makes healthcare workers feel seen and appreciated. Similarly, other communities will do things where the local businesses and groups host fundraisers, specifically with the proceeds going to recruitment efforts and new physicians. They will hire their own recruitment agencies to bring people from overseas. Town provides free passes and such to retain current physicians. So there's often physician appreciation packages with free access to town events, kids events, that sort of things that just say thank you to the physicians currently in the community. Another example or way that we could possibly increase physician recruitment is how easily people are able to settle into the community when placed here. So perhaps a welcome wagon, some kind of a main contact person to assist this new physician with troubleshooting challenges. Like Dr. Jawed, for instance, started September 19th, was not in the community until a week before, had no idea where to live, no idea where to get daycare, how to enroll her child into school, any of that. And I do think she would have had a better experience had someone been there specifically to help guide her through her questions. Perhaps a group of knowledgeable community members that offer to volunteer their time and expertise in supporting that new physician, an accountant, a lawyer, a real estate agent, an insurance agent, a town staff member, anyone that can be a first contact for them. Other towns provide things like negotiating preferred rates at local businesses, or MDs can buy vehicles, winter tires, other services at reduced costs. Again, really just about retaining the physicians that are here and making them feel appreciated. Again, another idea that could possibly help having them choose Neepawa is some kind of a town-wide housing strategy. So a town-owned house or a condo that a physician and their family can stay in while they get settled and look for more permanent options. This takes the pressure off them to immediately get into the community and feel like they need to purchase something. Gives them time to settle in, see what they like, examine their wants and their needs. Comparatively to other communities, there's different kinds of financial support. Other towns and RM contributions are significantly higher in other communities to local recruitment funds. Some have dedicated fundraising to cover any medically necessary equipment that is needed in communities, relocation allowances, return to service contracts, and bonuses. For example, one community in 2015 offered a $50,000 bonus for a 5-year return to service. And then in 2024, that had increased to $30,000 for 1 year and $75,000 for 5 years. So in October of 2022, the Manitoba Chamber of Commerce, together with Doctors Manitoba, published a joint recommendation report to attract and retain more physicians coming to rural and northern Manitoba. The take-home message from it, essentially, is that we all need to work together and prioritize recruiting new physicians. It can't just be one small local board, a recruitment board, the clinic itself. Everyone really need an all-hands-on-deck approach to it. Like I said, we need an all-hands-on-deck approach. The province, the local regional health authority, the community, and local physicians all have a unique role to play, and we really just need to prioritize and do it together with the hopes of getting more physicians into the community. So now that I had the joy of being the bearer of bad news, with all my statistics and doom and gloom, Dr. Milligan and Jenna will do the opposite and talk about our new residency program and the positivity that it will for sure bring to our community. So, their turn.
Introduce yourself and then move the mic after that.
My name is Jenna Kilburn and I'm the program administrator for the residency program here in Neepawa, and I'm fortunate enough to work with all the great doctors and especially Dr. Milligan in the clinic here.
And I'm Brian Milligan. I'm a family doctor here for almost 13 years now, and I love it. I think it's the best place to work in all of Manitoba and probably all of Canada. Yeah, thank you for the role many of you have played in that. Michelle does have kind of a sad talk to give. It's kind of a dire situation. There aren't a lot of doctors, but I do want to highlight one thing she said. It's not just Neepawa. It's not like everyone else is doing great and we're floundering. And I don't even think that people are passing us over and going to other small towns in Manitoba. I think actually compared to other towns in Manitoba, we're doing quite well. If you look at surrounding communities like Carberry or McCreary or Minnedosa, our emerge has never shut down. And so that's a lot better than a lot of these other places. I think the main issue is that there just aren't enough doctors. Right? So we have to find a way to make more doctors, and we've had medical students in Niqua for a long time, and we've had visiting residents in Manitoba or in Niqua for a long time. And I think that's one good step, and it has brought in some local doctors. I'm one of them. I worked with Dr. Parker for a little bit as a student before coming out here. Dr. Ong, sometime in that stint, was up all night with me at Subway when it used to be at the indoor pool hotel used to be. He was up all night. Maybe some of you were there. I remember there being Subway sandwiches, and he talked about all the wonderful opportunities there were in Niqua, and that was kind of what cinched the deal for me. And we've had some other learners come here, like Michelle talked about. Dr. Desley spent some time here as a student, Dr. Wareham, Dr. Cram. So it does sort of work, but we kind of felt it was time to take it to the next level. So we started talking to the University of Manitoba and see if we could actually host a residency program here. I'm going to back up a little bit and just explain how medical education works. First, you go for an undergraduate degree at university. You get your Bachelor of Science or your Bachelor of Music or whatever you want, some undergraduate degree. You have to take a few prerequisites like biochemistry and some more challenging courses. And then you apply to get into medical school. Medical school is 4 years. The first 2 years are mostly lecture-based, labs. It's all in a classroom setting. The second 2 years are more in the hospitals and the clinics. It's on-the-job training. So that's sort of where we got involved. The second 2 years of medical school is where the students have been coming from. And they, without exception, have said they've had a wonderful experience in Niqua. The patients have been wonderful to them, the staff are great to work with, the nurses are good to them, they're treated well, and they feel appreciated. They all rave about their time here. So that's good. After you finish medical school, you go on to the residency program. And a residency program is mostly on the job again, but much more higher level of responsibility. So you don't have to double check everything anymore. You can write prescriptions, you can order tests, you can see people without the attending physician like seeing them also. They have completed their medical school, they have their MD, but they need a couple years to fine-tune their skills and gain some of that independence and some of that knowledge. And so the attending physician is there to make sure that they're not making mistakes or not overlooking things, and just tweak their knowledge and make them a little bit better. We have had residents here also, and they come for a month at a time, and then they go off. So their main training programs are in Winnipeg or Brandon or Dauphin, and they come here for a month of rural medicine and see what it's like. After that, you're done, and you're completely on your own, and you got no backup anymore. So you can go work anywhere in Canada. Once you finish that 2-year program as a family doctor, you can work in the emergency room, you can work in a clinic, in a care home, in a hospital, whatever. It's kind of intimidating though. Like to go work in a place, let's say like Carberry, that has maybe one other doctor, you don't have any backup. And if that doctor's sick or that doctor's gone away for holidays, there's no one to call for help. So a place like Niqua that has 8 doctors, there's always someone else around to call if you need help or something like that, for support to bounce an idea off of. It's a good place. That was a bit of a sidebar. I just got this idea that how much I love Niqua, and that's one of the reasons I love it. Anyway, we are moving now from having a visiting resident come for a month at a time to hosting a residency program. So they will move to Niqua, they will have housing in Niqua, they will buy a house here or rent a house here for their 2 years, and most of their education will be in Niqua. They will, in the first year, spend 4 months at the clinic with one of the doctors there. They'll be assigned a primary preceptor, and they'll work with that doctor primarily. They will work with other doctors for on-call and at the emergency room, delivering babies in the operating room, but they have one main clinic doctor they'll work under. The benefit of having them here as our local resident is that they have to live here. They'll spend a lot more time here. They get to know the practice better. They get to know the community better. And we can kind of mold them and shape them a little bit more into our vision for what a family doctor should be. That'd be like a whole other talk, so I won't go too much there. But I think it's a really great opportunity to have more impact into their lives, into their future careers, and things like that. We don't have the volume of surgery that they need to get their training. We don't have the acuity of emergency room that they need to be here for the full 2 years. So they will spend time in Winnipeg and Brandon. The difference being that they will be visiting Winnipeg and coming home to Neepawa, or visiting residents in Brandon and coming home to Neepawa. So it's just it's a whole other ballgame, and they'll still get their excellent training and a good experience, but they'll be Neepawa-based residents. Hope that explains a little bit about what the whole system looks like and how they end up being doctors and what this residency program is about. Any questions about that so far?
Well, other than to say that thank you for doing it, because my niece was doing a residency. She had to go out of province to get it because we do not have enough residency programs. And so I was so pleased to hear, read in the paper that you were actually going to spearhead it. So thank you.
It's great.
How often, or how many resident doctors will you have here at one time? And how often do they rotate through?
Yeah. So each year we'll get assigned 2 residents. And it's a 2-year-long program. So for the first year there will be 2 of them. And then the second year there will be 4 of them. 2 first-year residents and 2 second-year residents. And then that will just kind of continually rotate. From then on there'll be 4. We have constant requests from the university to increase that number. Because right now, 20 years ago, as Dr. Packer about it, he will turn even more red than normal. And talk about how the government cut enrollment in the medical school and how they decreased the number of doctors that were graduating. We've been fighting with that ever since the 80s or 90s or whenever that was. And so now they're trying to catch up, and the government knows there aren't enough doctors and trying to find more spots to train them, but there aren't enough doctors to train the doctors they need, you know? So to give you a little bit of an inside story, I was trying to get this residency program going in Neepawa, and I thought I had this big uphill battle. I was trying to get a meeting with the university and trying to get a meeting with the university, and finally got one after a year and a half. And I thought I was going to have to learn a little bit about what was involved and maybe pitch my case, and they said, yes, so when are you starting in July? Good. And 2 residents, and you want 4? And apparently there's a term in the business world that got closed. I don't really know much about the business world, but that's what my brother tells me. So it's good. I mean, once we have more doctors, we'll be able to take more, but right now 4 is really the most we can take at one time.
4 and off-site residents as well, right?
That's right. So we won't stop getting the ones from Winnipeg and from Brandon coming for a month at a time. They'll come, and we'll still have the medical students coming. And so this is the 2 home-based people on top of everything else we're doing before, not instead of. Let's start with the cameraman.
So if we have 2 or 4 residents here in the residency program, does that mean more patients could be accepted into the clinic?
Not really, because they still have to have an attending physician looking over them. And so if they were to, they won't be booked specifically that resident because it's a 4-month block, and then they're going on to other things. So if they start something and then they have to go to their surgery training in Winnipeg, they won't be here to follow up on it, and then there's no one to do that. If we're fortunate, some of these residents will stay, and then for sure they'll be taking more patients.
With that shortage across Canada, really, of doctors, you mentioned in the 80s universities had a reduced number of doctors that they accepted and trained. Is that increasing now across Canada?
Yeah, it is. So when I graduated medical school, there were 83 graduates in my graduating class. It's over 100 now, maybe 110, 110.
Yeah.
So I try to tell Dr. Packer, calm down, that they're fixing it. They're increasing the number of med students, and he said, yeah, well, that's what it was when I went in school. It was 110. And so they're kind of getting back up to where it was.
How are the residents, the people in the residence program compensated? Are they on a contract, or how do they get paid?
Yeah, it's pretty tightly controlled union kind of contract that they get. It's paid through the health authority and the university. It's a combination of government, it's mostly government funding, and that's how they get paid. Yeah.
Would one of the biggest issues be for them to come here? Would it be housing?
they don't know that yet.
Okay, but they will sooner or later.
When they get here, but honestly, they probably, when they're trying to choose where to do their residency program,
Yeah.
they don't have a good grasp on how much housing is available in the community when they choose a residency program.
It's
They're
really
more-
our worry, isn't it? It's like our.
We're worried about it.
Yeah, it's our
Absolutely.
worry to find them housing.
So I guess what I'm getting at is that something that the community should be doing as
I
a
think it'd be
community to
great.
try and find a way to provide housing.
Yeah, and I thought myself, like, and then I was selfish and decided not to, but I thought I should buy a house and have it available for them. I'll have guaranteed renters to come, right? But I thought like in my position as a site director, I should probably stay at arm's length from that and not try to profit off my residents. And so I'm not going to, but any one of you should. We're getting 2 people a year, they will be good tenants. You know, they'll hardly be there, they'll be at the hospital most of the time. And they should take good care of the place. As a rule, they tend to be fairly responsible individuals.
Rotary Club had Rotary Exchange students come for a year at a time, and we would host them and so on. It became a little more difficult to get them. It might work with older students, residency doctors perhaps. Something maybe Rotary could look at, I don't know.
Yeah, are you suggesting that they would come and bill it with somebody, or that they would?
Yeah, well, it would be rent, I guess they'd pay, I suppose.
Yeah.
But, yeah, that host, whatever.
Are most of them have families though?
Yeah, that was the question.
That's the other reason I didn't buy a place.
Oh, okay, family.
A, it's hard to find a place. B, I wanted to stay at arm's length from it. And C, I don't know which resident I'm going to get every year. It's going to be a single guy who's 26 years old, or a 36-year-old woman with 3 kids and a spouse and 3 dogs. So I don't know what size of place to get. But somewhere there's a middle ground where they would be, you know, if you had a smaller house, it would be great for them to have, or they might want to choose to be roommates and stay here. I don't know how that all works, but
in most cases, if you have 2 coming, you're probably going to need 2 different accommodations.
yeah. So it's probably 4 housing units,
Yeah.
and I imagine one of them would be happy with an apartment, and there might be one that has a family and needs a house and a dog or something, if I were to average it out. I think most of them would probably be a little bit beyond the stage where they're happy to be building it out, or like live with another family. I think they're going to want their own space.
Yeah.
Right, yeah.
Partly to the benefit of whoever's hosting them, because they'll be coming and going all hours of the night, and partly they're just going to want some of their own space sometimes to be quiet or study, or mostly study. Terry, you had a question?
So if a resident is not able to be a family doctor, they're not able to be assigned that, they would work with you. How do they change your workload?
It depends a little bit on the resident. Most of the time they ease my workload, and so if I have a resident, I can probably accommodate more patients in a given day, because I don't have to spend as much time with each patient the resident sees. So most of the residents, especially in the second year, will be independent. I'll read through their notes at the end of the day and make sure that I didn't miss anything, and we'll talk about a couple challenging cases, but mostly I'll read their notes and agree with everything they said, and then carry on. So every patient they see, I don't have to see, which frees up time for me to see other people.
So it goes beyond just hopefully retaining them at the end of the residency as a family doctor that would continue on, but it actually enlarges your influence, your ability.
So I would say if I normally see 25 to 30 patients a day in the clinic, with a resident here, I might be able to see 30 to 35 when they're in their second year of residency. In the first year of residency, it's probably going to be about a wash. It'll probably be leaving because I'll have to spend a little bit more time with them. That also only applies when they're here. So when they're on their off-service rotations doing surgery or anesthesia or emergency room or ICU somewhere else, then I don't happen to have that increased throughput.
With the new hospital, there'll be less going elsewhere for some of those people if we can obtain some of that services in the new hospital?
Yeah, already now, with what we do, so instead of having 3 months of obstetrics, they're going to have 2 months of dedicated obstetrics and the equivalent of 1 month of a longitudinal. So they'll be delivering babies in Niqua and getting that experience. But if we deliver 120 babies a year in Niqua, they deliver that a month in Brandon.
Yes.
And so they'll see a lot more volume if they go in those bigger places. But so that's why it takes about a year to have about a month's worth in one of the higher facilities.
I'm curious a little bit about the training of doctors, and you said Manitoba cut back. Was the cutbacks all across Canada? Like all provinces sort of cut back in the 80s, or just here?
I don't know, I was running on a soccer field then. I hope Dr. Clark is watching this someday. I teach him mostly because I hold him in like a high esteem, and I want to be like him someday in terms of medical knowledge someday. But I don't know if it's the 80s or 90s or when it was, but I mean,
there were, what I'm getting at is there were cutbacks, and that's probably the issue why all across Canada we haven't got enough doctors. The one question
one contributing factor. I wouldn't say it's the only one. There's one contributing factor.
There was a time where lots of Canadian trained doctors were trained in Canada and then chose to go stateside or elsewhere to work.
Yeah.
Is that, there's still a drain to stateside or not?
Not at the family doctor level.
No.
No. I don't know much about the specialist level. There might be. Some of the very specialized doctors have difficulty actually finding work in Canada, so they have to go other places.
Any other questions from?
Unless you got to kick us out.
Yeah, no, you got time. Yeah.
I promised Jenna I wouldn't make her say anything. The best thing that happened to Neepawa since, in the medical community, since we got this residency program was hiring Jenna. She is fantastic, and her vision for the residency is going to be amazing. And so if my job is sort of to be like the principal and make sure that they're like adequately trained physicians by the time they graduate and their medical knowledge is good enough to get the stamp, her job is to be like the den mother. She's going to be the one who takes good care of them, who makes them feel welcome, who gets them involved and make sure they have good personalities and all this kind of stuff. And she's great at it. Like she already, this morning we were talking before we came here, said, well, yeah, we could have them do this, and we could have them do this. And so instead of me like just saying what you told me this morning, do you want to say it? Or do you want me to say it?
Go ahead.
I did promise not to make her talk, so I want your opportunity, but some ideas she had, and this is maybe a little bit more relevant for the Rotary Club in particular, and your experience in terms of business owners and professionals in the community. We want to have our residents be active members of our community. So we want to get them involved as volunteers. So if there's like a mom's morning out thing and they want to do a teaching session on breastfeeding, or if there's a toddler kind of mom's group and they want to talk about the importance of dental hygiene, or not putting Coke in your child's bottle, and, you know, things, it's important things to learn. And so they can, that would be a great spot for them to go and get involved. And Jenna had a list of 4 or 5 other things we get them involved with, but just to sort of, for that to be turning around in your mind, if you think of any community organizations that could benefit from having a resident come and give a talk once a year, twice a year, something like that. We're going to try to get them involved with some team clinics in the schools, talk about relevant topics for teenagers. And
Salvation Army and the programs that they offer to the community is something that we'd like to get involved with as well, and the fire department, that sort of thing, yeah.
We are, on another level, something that Rotary could get interested in potentially is with the education itself. So not all the learning is like with patients, and you'll be glad to know this, that look, it used to be this way. In fact, when I trained, it wasn't this way. We didn't have sophisticated, high-fidelity plastic dummies to practice on, and so there was someone, we needed a tube on the chest to drain fluid or drain air that had collapsed lung or something. We did it on the patient the first time. We looked for a long time for suitable models, but there just weren't any. But now there are, and so they have these things called sim labs, which stand for simulation labs, and they're basically really fancy CPR dolls. You know, they're hooked up to high fidelity equipment, they are hooked up to monitors, they're computer systems programming. You can learn to do CPR properly, you can learn to put a breathing tube in somebody, you can learn to stick a garden hose in their chest to save their life, and all these fancy things you can learn to do in a group setting. And it's sort of like this area of medical education has taken off in the last 5 to 10 years. Most of the residency sites have one of these mannequins, but the university doesn't have enough money to supply it. And so the sites rely on community organizations, hospital foundations, Rotary clubs, other service groups to sort of raise funds and try to purchase one of these things. I don't know exactly how much it costs. I think it's $80,000 to $100,000 for one of these things. It should last quite a long time. 80 to $100,000, yeah. So it's a big ticket item, and we won't get it. Never say never. I don't anticipate getting it before the residents come in July. And so what we've done is we've teamed up with Dauphin, and so when we have these academic days and teaching sessions, Dauphin has one of these dolls, and so we're going to drive our residents up there, spend half a day with them, working with this doll or doing some other education thing, and then come back.
One thing that was mentioned when I was up in Dauphin with one of my colleagues, she said that one of the benefits of having it on site is that when something happens in clinic or in the hospital, it's good to practice and learn that day. A month later, when you get up to Dauphin or Brandon, it's not as effective, so that any physician in Neepawa can benefit from it, having it on site.
Yeah, I think what you're saying is if there were a situation in the emergency room where someone needed a big procedure like this, or there was a big trauma that came in or something, generally there's 1 or 2 doctors going to be working on it, but there'll be other people there, you know, available to help or whatever, but they won't actually get the hands-on practice of doing it. But if it's fresh in their mind, seeing it and hearing it and see how it goes, you come back and rehearse it on the doll afterwards, then everybody gets a chance and you can sort of all learn and debrief from each other on how to do it better.
So what you're saying is we need 100 people with $1,000 to buy it?
Exactly.
No, it's a good bang for your buck. It is. As a community, we all don't want to need it, but yes.
But, you know, I go back to when the Roxy Theatre was looking at having an upgrade, and they're $80,000. Well, how are we ever going to raise $80,000? And I said, that's easy. Just break it down to a per person. So this many people need to do this many people need to do a little bit less. And so, now if we really put our minds to it, we could probably do it, I wouldn't say by July, but you know, the potential is there, and working through the Neepawa Hospital Auxiliary who have charity status, would, you know, I guess we need people to lead the charge and do that sort of thing, because I'm sure the money's there, but we got to ask.
Awesome.
Yes. I'm excited to partner with anybody from the Health Auxiliary, and I'll be looking into that. Like this week, I'll do it this week, yes. Yeah. Yeah.
Told you she's all right.
That's a good time, sort of in November, when people are looking at year ends, but no, anytime people are looking for places that make sense to donate funds to it, and what you do explained, and Dave's got it on tape for us today, to explain why we should do this.
Especially if they can get a tax receipt for it.
That's right.
Anything else?
I think we can find a way to do that, either through the university or through the health auxiliary. I think there'll be a way to get a tax receipt.
Yeah. Well, it's easy because the auxiliary is here, so.
The health auxiliary is able to give out tax
Perfect.
receipts.
Yeah, okay, great.
Okay, thank you very much. A very informative presentation. So the next prescription that you have to write. Thank you. I know you do it all by computer now.
Thank you.
It'll still come in handy. So, thank you very much. Very informative presentation.
Right. Good afternoon, folks. How's it going? Thanks, everyone, for joining us here today. Budget day in Manitoba. Good news today. So I want to begin by acknowledging that the work that we carry out as the Manitoba government happens across the traditional territories of the Anishinaabe, the Anishinaabe, the Cree, the Dakota, the Dene, the Métis, and the Inuit peoples. I also want to give a shout out to my colleague, Adrian Sala. His first budget here today is a significant document. It charts a very positive path forward with significant investments in healthcare and lowering costs for you and those who need it most.
This document also has a path to balancing the books within 4 years. And with that, and with so many other healthcare initiatives, economic initiatives, affordability measures to help you and those who could really use some help right now, we're delivering on a huge number of the commitments we made in the recent provincial election. So I want to say that Manitobans have chosen a direction, and we're very honored to have the opportunity to bring that forward here in our first budget. This document, One Future, One People, One Manitoba, is the result of tons of conversations that we've had across the province, a huge amount of work that has gone into identifying the needs and to listening to the challenges, but also hearing the opportunities that Manitobans are excited about for our future. Over the past few years, especially because of the impacts of the pandemic, there have been so many reasons for Manitobans to be divided. And our team takes very seriously the message that we've heard that it's time to find reasons to bring people together. And we don't have to agree on everything in order for us to do the big things together, like fixing healthcare and lowering costs in this present economy. So there's a number of initiatives that we're very, very excited to be able to commit to today. The theme of this budget, in addition to unity, is about delivering more help for you and more help for those who need it most. When we're talking about people who need help, we know that those on the front lines of our healthcare system have been crying out for investments. Today's budget brings forward $1 billion new in healthcare investment that is going straight to the front lines. Every single new federal dollar is going to the front lines of our healthcare system, not just the Canada Health Transfer. The equalization investments are going to the front lines as well. What that's going to produce this year is 1,000 new workers on the front lines of our healthcare system. 100 new physicians, more than 200 new nurses, 90 new paramedics, 600 healthcare aides. And again, the challenge that we face in healthcare isn't going to be solved overnight. But based on the investments in this document, you are going to start seeing improvements in healthcare this year. We also are committed to moving away from papyrus as the medium of record in healthcare. And this year, we will be bringing in plastic health cards here in the province of Manitoba. And, of course, we're honoring our commitment to build a new emergency room at the Victoria ER as well as in Eriksdale. And the design work to get those projects started is included in this year's budget document. Of course, we know that we need the staff to be able to do so, and that's why our healthcare commitment starts with the staffing. But we're seeing encouraging enough news on the recruitment and retention front to be able to move ahead with the emergency room commitments. So this document has brought forward and unified many of the opportunities and challenges and thoughts and dreams that we've heard from Manitobans. And that's why we're very proud to bring forward this document, One Future, One People, One Manitoba, so that we can continue to work together in making this province such a great place to grow up and a great place to grow old. So on a personal level, it is a huge honor to have the opportunity to bring this forward for you, the people of Manitoba, to have the opportunity to work with my colleague and others to undertake this challenge on behalf of the people of Manitoba. And so I just want to acknowledge that today is a big day for my colleague, the Minister of Finance, here as well. So Minister Sala, please.
Thank you so much, Premier, and thanks to everyone for being here with us today on this very exciting day for our province. Today, we are introducing our first budget to rebuild healthcare and to lower costs for families in our province. It's been a very challenging 7 years here in Manitoba. The previous government cut healthcare, they closed desperately needed health centers and ERs, and they disrespected the hard work and skills of frontline workers in Manitoba. They failed Manitobans when they were sick and when they were vulnerable. And in those 7 years, under the previous PC government, families saw their costs go up and up and up. They spiked hydro rates, they increased rent, and they passed on the costs of a slowing economy because of their decisions onto the people of Manitoba. It's left people struggling to keep up and to save for the future. Now, in the face of these challenges, it would have been easy for folks to feel helpless and to give up. But that's not the Manitoba way. And as the Premier just stated, what we saw instead was a province who chose a new path. Manitobans chose to believe that we could do better for the people of our province. And 6 months ago, they chose to elect a new government. We made a commitment to the people of Manitoba that we would put Manitoba on a positive path forward by rebuilding healthcare and by bringing in lower costs for you and your family. Today, we are delivering on that promise. Budget 2024 delivers help for you and for those who need it most. We're starting by staffing up healthcare in Manitoba. That sense of hope that the Premier alluded to, the way we keep more folks, like the nurse who wants to stay on, is by reducing the pressure on staff, by bringing in more healthcare workers to the front lines right away. In Budget 2024, we're hiring 1,000 new healthcare workers, 100 doctors, 90 paramedics, 210 nurses, and 600 new healthcare aides. And with these staff, we can build out our healthcare system with smart and targeted investments. This means more ICU beds, more rural and northern care, more clinics, expanded cancer care, and reduced ER wait times. With more staff and less pressure on existing ERs, we'll be set up to start the building at the Victoria ER. This budget has the funds to start that work right away. We've heard from staff and from families about what this new ER will mean for South Winnipeg. It means that more staff will be able to focus on delivering the care that they trained for. And it means no family will have to drive past the Vic to another ER further away during an emergency. We've laid out a plan to build up a strong healthcare system where you get the care you need at every stage. And while we work towards this, we are taking common sense action to make existing services better for you, like finally bringing in plastic health cards and getting rid of the wait time to get your card replaced. No more torn, soggy pieces of paper to get the care you need. Because it's about time healthcare in Manitoba worked for you, from health cards to ERs and everything in between.